Thank you very much for your kind presentation. بعدين بقول لك شو هي الألفا أوميجا ألفا. So I'll be talking today about thalassemia and malignancy. This is a new topic. We've talked about it in few previous meetings. We're gathering more and more data. So after all the discussions in the morning today, we talked a lot about ineffective erythropoiesis, about hypoxia, about iron overload. All of these might play a role in this. This is my disclosure. Presented it in the morning. So I'll start with very short two case presentations, after which I will briefly highlight some issues related to cancer and thalassemia. So the first case is a 42-year-old male, a case of TDT, has an elevated serum ferritin and LIC level. He is hepatitis B and C negative by PCR. He was hospitalized in 2014 for epigastric pain. When he was scoped, he was found to have esophageal and gastric varices. The patient presented again for epigastric pain, unintentional weight loss, and worsening jaundice. He underwent an MRI, and his MRI showed these masses in the liver. So the diagnosis was bifocal hepatocellular carcinoma. So the first case shows you a transfusion-dependent patient who is severely iron overloaded, who is hepatitis C negative, yet he developed hepatocellular carcinoma. So we cannot say only that hepatitis C is the cause of hepatocellular carcinoma in our patients. Age is very important, and I have already highlighted the importance of aging in our patients. The third lesson that we would learn here, that any mass should not be considered as extramedullary hematopoiesis and be missed, because we are missing some of the extramedullary hematopoiesis, of some of the malignancies, and saying that they are extramedullary. Our patients are getting older. They should have, and they might have, problems other than the problems that we only see in thalassemia. The second case is a 62-year-old lady, non-transfusion dependent thalassemia, who has right upper quadrant pain and splenomegaly, but she was transfusion independent for a long period. She presented with a painful, painless left frontal mass. That was the presentation, and even from her features you could see a case of thalassemia. So that mass was there. A lot were saying that this is extramedullary hematopoiesis. A scan was done, a biopsy was done, and this was large B-cell lymphoma. Treated for the large B-cell lymphoma, and she was cured. The second case also represents an elderly TDT presenting with a mass, and once again, these patients should be screened for other causes than what is well known. The other issue in that patient is that she started to require more blood transfusion and her spleen increased. And we always say, yes, she's an intermediate. With time, she will increase her spleen and she will start to get more transfusion. But apparently, when she was treated for her malignancy, she did very well. So once again, keep in mind that these patients are getting older and they can have other problems other than the ones which are common. I will not go through the definition, but we've already talked a lot about it, talking about NTDT versus TDT, which is, I think by now, it's clear to all of you, where we are using transfusion as the marker to classify the disease. But what is important is that when we talked about the pathophysiology today, we highlighted that there is an interaction between ineffective erythropoiesis, hemolysis, iron overload, splenectomy, and hypercoagulability, all of these leading to problems in our patient. An important slide that I have showed you at the beginning shows you that these patients are getting older. This has resulted in an improved good chelation, good transfusion, has resulted in improvement of life expectancy, and as a result, we are getting a lot of evolving concerns when the patients advance with age, including malignancy, renal disease, and other issues that we are going to talk about during this meeting. And from the UK data and from the Italian data, also from the data that I've shown you in the morning from Greece, malignancy is surfacing as one of the major issues of morbidity and mortality in our patients. So keep it in mind, and every time I'm on a stage or in a virtual meeting, I always ask the Arab group or we as a group to collect our data on malignancy and maybe in a simple way similar to what we have done in the optimal care and just publish the data that we have. Also from other sites showing that malignancy is high on the list. So beyond the increased risk of cancer due to prolonged survival, does the disease and its management further increase the risk? So ما بدنا نقول إنه بس it is due to aging. Maybe this is due to the disease itself or due to the treatment of the disease. So if you look at this individual, and this is one of the interesting papers, you would see that that person at one side we have the thyroid cancer, the hepatocellular, and you could add to it the renal disease, and on the other side you will have the lymphoma and some of the hematological malignancies. So at one side you have the solid tumors, and the other side you have the hepatocellular, you have the hematological malignancies. We have very few studies on cancer in thalassemia. These are two good studies. One is from Iran, from Mehran Karimi, and the other is from Asia. In both of these studies, it is clear that malignancies in patients with beta thalassemia major and beta thalassemia intermedia are higher in this group of patients. Also, the Taiwan study, which was an excellent study, population-based cohort study, where the objective was to investigate the incidence and risk of cancer in around 2,500 patients. The overall incidence of cancer was 1.5 times higher in the thalassemia cohort compared to the other cohort. So if we want to talk about solid malignancies, which is mostly papillary carcinoma of the thyroid and hepatocellular, as you know, in the solid organs, the main mechanism would be iron overload, where papillary carcinoma can be detected in the thyroid, hepatocellular, and renal cell carcinoma. We're seeing more and more patients with renal cell. So, and in addition, in hepatocellular, keep in mind hepatitis C, although they might get hepatocellular without hepatitis C. The pathophysiology of the iron-mediated toxicity in hepatocellular is, as we were talking just before Ryan was talking about generation of reactive oxygen species, formation of toxic byproducts that impair protein synthesis, disrupt the DNA, mutations in tumor suppressor genes and DNA repair gene, and promotion of malignant transformation through acceleration of fibrosis, cirrhosis, and ultimately hepatocellular carcinoma. This is also shows you that there are other factors, alcohol, obesity, insulin resistance, fatty liver, that would add to this hepatocellular carcinoma in our patients. The epidemiology of hepatocellular carcinoma, there are few studies that I've updated the presentation and I have added them here. Some of them are from Greece, others from Italian registry, also showing increase in hepatocellular carcinoma among thalassemia patients. This is from one of my young students who was working with me at one time, where we reviewed and tried to prove that hepatocellular carcinoma can occur due to iron overload and not only to hepatitis C. As this is a very common question asked by our patients or their family, how should we follow up our patient, our children or our patients with thalassemia intermedia or with the anti-DT and look into hepatocellular carcinoma? So the evidence of, I tried to review the literature to look into the evidence of solid malignancies, and you would see that the majority are either case reports or small series, around 3 or 4. شو هاي اللي عم تقلب لوحده؟ Around 3 or 4 of these comes from my center, where I follow around, let's say, 1,200 patients. So I'm sure the data should be much larger in Egypt, where we could have more data. So I talked about solid tumor, now the hematological malignancies, and as you notice, lymphoma would be high on the list in this group of patients. Could it be to the added value of some viruses? Could it be due to the overstimulation of the bone marrow due to ineffective erythropoiesis, JAK2 mutations, and chronic hypoxia? And this is something that we should keep in mind. ما عم بقول لك عملت شيء، بس عم بقول لك ليه عم تبرم. حبيبي مش قاعد اصبعي انا وين. So hematological malignancies are more common in this group of patients. This is reviewing the literature, also showing you that in TDT and NTDT you can find hematological malignancies, including lymphoma, leukemia. I've seen 2 cases of myeloma, which I've reported. An NTDT patient coming frequently for transfusion, was never transfused before. So thinking that you should do a bone marrow because it might be another reason for the anemia. So what are the possible mechanisms of hematological malignancies in thalassemia? Ryan talked a little bit about the ROS, iron overload, hydroxyurea use, viral infections, blood transfusion, bone marrow stress. All of these might lead to lymphoma. Keep this in mind specifically. Keep this in بفتكر لما اعمل لها تايمر. Keep انا بدي اعملها كيف بدي اعمل لها تايمر؟ okay. طيب. So always keep this in mind, specifically that we will be using new products now, like luspatercept and other, where one should always keep in mind activating the bone marrow might lead to, and this is why we looked into this specifically, but as Khalid presented, no cases of malignancy were reported, and similarly in the beyond. So iron overload and transfusion therapy might aggravate genomic instability, immune regulatory imbalance, and can promote cancer development, viruses, hormonal therapies also in our patients. Hydroxyurea, although the data is very rare, but always keep in mind that your patient might be receiving hydroxyurea, which might cause some a small risk. So it is really very important to screen our patients, and the screening program should be implemented, and we should add it to our guidelines. Surveillance for hepatocellular carcinoma should be performed at least once a year in TDT, twice a year in NTDT, specifically if they are infected with hepatitis C. Caution should be used with hormonal therapy, and always try to treat with the new antiviral, the hepatitis C. Also, if iron overload is a cause, keep in mind that you need to chelate your patients properly, and chelation therapy is still a very important part of the management and would remain for our patients. So I tried to review this very quickly because I noticed that there is a second presentation also on malignancy, so that ما بحرق الموضوع يعني. So this is حرقت وخلصت ولا ماشي؟ طيب خليت لك 50. And this is the review that I have published with our team in blood review. So a good idea would be to collect our data and hopefully try to publish something different. Thank you.